Committee hearing of the 119th Congress will come to order. I want to thank the witnesses for being here today to discuss the Electronic Health Record Modernization Program at the VA. Appreciate your willingness to participate and help in this conversation. Before we get to the business of today's hearing, I want to first congratulate and welcome my fellow Midwesterner, Representative Nikki Budzinski from Illinois, on becoming the ranking member of this subcommittee. We had a great meeting in my office a few weeks ago and participated in a roundtable earlier already, and really appreciate your partnership in this effort. Your position as ranking member is a testament to your hard work for veterans and the goodwill you have built with your colleagues on both sides of the aisle, and look forward to continuing to build that relationship together. Our work on this committee will not always be easy, but our mission is critical, and that's why I'm deeply honored to chair this subcommittee and lead the House's oversight over VA's IT systems, infrastructure, and modernization projects. By way of background, I served 22 years in the United States Army before retiring and becoming one of the thousands of veterans in Michigan that receive their health care and benefits from the VA. I personally go to the VA, the Battle Creek VA Medical Center. I use the Montgomery GI Bill to pay for my college, and I understand what veterans in Michigan and across the country need and expect from the VA. I'm going to use my leadership position here to make sure that VA's IT systems are working for all veterans and employees of the VA, and ultimately making the VA a more effective and efficient organization. Whether you're making primary care appointments, filling a disability claim, applying for education benefits, none of that happens successfully without good, reliable, and secure IT systems. Perhaps the largest undertaking on this committee will be oversight of the VA's electronic health record and the efforts that are going into that today. It's the backbone of VA's healthcare operations. The Electronic Health Record Modernization Program is VA's project to replace its homegrown electronic health record system with a commercial, off-the-shelf EHR from Oracle. This subcommittee has spent hundreds of hours over the last several years conducting oversight over this program and exposing and reviewing and analyzing its issues and its problems. While I'm new to this conversation, I've spent considerable time looking into this issue. I understand how important it is for us to get this right. These consistent problems include system outages, patient harm, poorly functioning technology, budget overruns, reduced patient volumes, and more. Because of these problems, former Secretary McDonough put the program in an indefinite pause in April of 2023 to give VA and Oracle time to fix a long list of problems with the system. The Secretary decided right before Christmas that VA was going to start the program up again in the spring of 2026 at Ann Arbor, Battle Creek, Detroit, and Saginaw, in my home state of Michigan. 2 years ago, VA told this committee they had a lot of homework to do before they put this system into another medical center. Now, VA is getting ready to turn in their homework. I appreciate the opportunity to meet with both Oracle and VA several times before this hearing to discuss the problems that have plagued this system for years. While I'm not convinced that they have fixed all of the problems, I want to hear today from VA, and Oracle directly to this subcommittee that progress has come out of the last 2 years. As the new chairman of this subcommittee, I'm going to examine the facts, consult my colleagues on this subcommittee, and make my own judgments based on what progress has been made. Here are some of the facts as they stand today. First, VA is nearly 7 years into the original 10-year contract, and the Oracle EHR has been implemented in less than 4% of medical centers. Second, according to latest surveys, 69% of users are dissatisfied with the system. 75% of users believe the system does not maximize their efficiency. I told someone earlier that the approval rating is less than that of Congress, and that is a hard thing to do. Third, Congress has not received a schedule nor an up-to-date cost estimate to evaluate this program's current state. The only independent cost estimate we can rely on for what it will cost VA to implement this program is already 3 years old. It was over $32 billion. That's more than double VA's original estimate of $16.1 billion. Given these facts, VA needs to demonstrate how this system has improved and explain why this program can succeed before starting up again. I have confidence in the Trump administration and Secretary Collins to right the ship for veterans and their families, and I intend to work closely with him to deliver results. It is my commitment to this subcommittee and the stakeholders here that I will be firm but fair in the oversight we provide. Thank you all again for being here today. I look forward to your testimony, and I look forward to achieving the accountability that all of us should expect. With that, I yield to Ranking Member Baczynski for her opening statement.
Thank you very much, Mr. Chairman, and I want to start out as well congratulating you on your chairmanship of this subcommittee on technology and modernization, and to say genuinely how much I look forward to working with you on this issue. In addition, I'm working on this issue as a ranking member because I think it is so important that we're ensuring that veterans and VA employees have the access to state-of-the-art technology that supports the delivery of health care and benefits for our veterans. I also want to thank the witnesses for being here today to discuss the future of EHRM, this project, and for coming in a couple of weeks ago to help me get up to speed on a lot of these issues. We had a robust discussion about the history and the current status of this project, which I really appreciated, and I look forward to working with all of you to support the progress that has been made to ensure that the EHRM moves forward in a safe and a smart way. In almost 2 years since the VA announced its reset of the EHRM program, we have worked in a bipartisan and bicameral way with VA and Oracle to move the needle on this project. In December, as the chairman mentioned, VA announced its intention to resume go-live activities with the first deployment happening in mid-2026. I want to take this time to outline some of my concerns, many of them that I share that the chairman has actually already outlined, about the lack of progress being made by both VA and Oracle on a series of issues that ultimately impact our mission here, which is to address the betterment of veteran health and safety. Last month, VA briefed my staff that there was still dozens of outstanding recommendations from the VA's Office of the Inspector General and the Government Accountability Office. Recommendations that VA acknowledged it needs to fix, and yet has little been made on progress on those issues. It seems to me that these recommendations need to be addressed before any other go-lives are allowed to occur. I hope to hear from VA about how it intends to address these open issues before its planned resumption of go-lives next summer. I think that's important. I'm also concerned about the rollout of the 3B bidirectional interface intended to fix major issues with how Oracle supports VA's pharmacy operations. I understand that 3B was deployed this weekend, but it sounds like it's suffering from some of the same issues that the system did during its initial go-lives. The training is substandard and behind schedule, and staff are concerned that the solutions won't meet their needs. The 3B solution was meant to solve problems that were identified at Mann Grandstaff, the first site to go live in 2020. Yet here we are almost 4 years later, and I'm concerned that this is still not fully ready. The lack of these fixes has caused VA Pharmacy to hire additional people and use onerous workarounds to accomplish the same tasks they did in Vista. These fixes are desperately needed, but they need to be done right, and we cannot afford any more half measures. Also, I have some major concerns about how the recent reduction in force actions at the department are going to impact VA's ability to move this project forward. I know that Secretary Collins says these actions will not impact veterans' access to health care and benefits, but I don't see how cuts to a historically understaffed VA don't impact veterans, and specifically the implementation of this program and our look ahead to these go-lives potentially in 2026. I have questions about how many people in the EHRM integration office were terminated under the probationary employee purge, how many opted to take the fork in the road, and how many others may have been purged through other methods. I also have questions about how the hiring freeze is impacting EHRM. I expect the VA has a plan to compensate for these vacancies in this crucial program, and I need to hear about that plan today. My biggest concern as we continue overseeing the EHRM program is ensuring that veterans' health and safety remain the top priority throughout this implementation. However, VA's track record has not always aligned with this commitment, also oftentimes prioritizing speed over execution. VA rushed into this contract accepting a false assumption that it had to be on the same system to be interoperable with DoD. It rushed into system configuration without doing the standardization work needed to make the transition smooth. It rushed to go live even though we were in the middle of a pandemic and all the VA staff were already overworked. It then rushed to move on from its initial failures. VA even allowed DoD to rush them into another go live, just so DoD could finish its project. We cannot allow VA to rush into the resumption of go live activities using the same old playbook they've used up until this point. The department must focus on improving their protocols, training, and efficiency on the front end before hastily implementing another go live. I want to say, though, we should be working toward this go live. I have all of these concerns. I think it's important they be articulated, but I do want to get to a point where we can see this being successful, but I need to hear meaningfully how these concerns are being addressed before we can do this. The focus should be on improving staff training, for example, to ensure that the tools and skills to be able to use the software most efficiently. The focus should be on establishing a structured project management timeline, something that I think the chairman has also brought up, with benchmarks and deadlines that must be met to push the project to the next step and eventually go live. The focus should be on implementing a system that maximizes efficiency within the VA and allows providers to have seamless communication with other elements of the care delivery system. We quite simply owe it to veterans and VA employees to ensure that they have the resources and technology they need for high quality, safe, and effective care. So I look forward to this conversation, and thank you very much, Mr. Chairman. I yield back.
Thank you, Ranking Member Budzinski, and I'd like to introduce our witnesses. From the Department of Veteran Affairs, we have Dr. Neil Evans, Acting Program Executive Director of the Electronic Health Record Modernization Integration Office. Did I get all that right, sir? All right. From Oracle, we have the Honorable Seema Verma, Executive Vice President and General Manager of Oracle Health and Life Sciences. From the Government Accountability Office, we have Ms. Carol Harris, the Director of IT and Cybersecurity at GAO. And from the Office of Inspector General, we have Mr. David Case, the Acting Inspector General of VA OIG. I ask the witnesses to please stand and raise your right hands. Do you solemnly swear under penalty of perjury that the testimony you are about to provide is the truth, the whole truth, and nothing but the truth? Thank you, and let the record reflect that all witnesses have answered in the affirmative. Dr. Evans, you are now recognized for 5 minutes to deliver your opening statement on behalf of VA.
Thank you. Good afternoon, Chairman Barrett, Ranking Member Budzinski, and distinguished members of the subcommittee. I want to thank Congress and this subcommittee for the opportunity to testify today. VA recognizes and appreciates your shared commitment to veterans and your support for VA's electronic health record modernization efforts. This testimony comes at a pivotal moment. With new leadership at VA, there is renewed commitment to ensuring that every aspect of our EHR modernization effort is reevaluated. Secretary Collins made it clear in his confirmation hearing that the status quo is not acceptable. Every previous decision, policy, and process must be thoroughly reviewed to ensure that it aligns with our core mission, providing veterans with the highest quality care through a system that works for them, not against them. Accordingly, VA remains committed to implementing modern interoperable health information technologies across the entire VA healthcare system. The federal EHR, which is the set of technologies we are deploying through our electronic health record modernization efforts, works in concert with biomedical devices and other critical health information technologies. And these together will serve as key enablers behind VA's ability to deliver comprehensive, high-quality health care to veterans for many years to come. Between 2020 and 2022, VA deployed the system at 5 VA medical centers, 22 community-based outpatient centers, and 52 remote VA sites that serve those clinical locations, for example, call centers, telehealth hubs, and more. In April of 2023, veterans and staff had made it clear that the system was not meeting expectations. And with bipartisan support from this committee, and consistent with recommendations shared by GAO and OIG, VA announced a comprehensive program reset, pausing further deployments of the system and taking time to address issues that have been identified by users at active sites. VA also identified the reset period as an opportunity to complete foundational enterprise work necessary for long-term success, operating a far more centralized set of technologies than VA's existing electronic health record. And finally, VA used the reset period to prepare for and then successfully complete a joint VA-DoD deployment of the federal EHR at the Captain James A. Level Federal Healthcare Center in North Chicago, Illinois, just under a year ago in March of 2024. Relying on a data-driven approach to assessing progress, VA demonstrated improvements in system stability, program processes, veteran and VA staff experiences, and finally, health system outcomes, including quality, clinical productivity, and revenue management. And in light of that demonstrated progress, on December 20th of 2024, VA announced that it was going to restart federal EHR deployment efforts, initially at the four aforementioned Michigan facilities in Ann Arbor, Battle Creek, Detroit, and Saginaw. I should add this: VA acknowledges that there is still improvement work to be done, as you will likely hear from GAO and OIG. And we agree. Improvement efforts are not stopping. We are simply, in addition to those improvement efforts, resuming deployment work in parallel. Examples of ongoing improvement efforts include migration of the system to Oracle's cloud infrastructure for improved performance of the system and access to Oracle's next-generation technologies, establishment of a federal EHR system baseline and associated processes, which is a critically necessary step in support of improved standardization across VA, which will help lessen staff frustration, deployment delays, and cost. Further training improvements to better support user adoption, standardization and consolidation of user roles in the system, which will simplify training and everyday use of the system for VA staff. Completion of cross-cutting projects that we've called Big Rocks, which include reassessing system design choices in order to deliver a better and more efficient user experience. And there's much more. Meanwhile, current state reviews, the initial activities necessary to deploy the federal EHR, have been in progress at the Michigan sites mentioned earlier since the first week of January, and those are going well. We are also working closely with VHA health system leaders and with Oracle Health to determine deployment plans beyond the Michigan sites. These decisions will support the iterative development of a revised integrated master schedule, in addition to updated cost estimates for this project. Through the efforts of the recent program reset, and through our collaboration within VA with our end users, with leadership, and with veterans, and outside of VA with DoD, firm, oversight bodies, and our vendor partners, we are seeing movement, yes, even momentum in the right direction. By sustaining these efforts, our velocity should increase over time. VA remains optimistic to realize the successful implementation of the federal EHR across VA, and I appreciate this opportunity to testify and am thankful for this committee for your commitment to serving veterans, and look forward to working with you over the course of the 119th Congress. We look forward to responding to any questions you might have.
Thank you, Dr. Evans. The written statement of Dr. Evans will be entered into the hearing record. Ms. Verma, you are now recognized for 5 minutes to deliver your opening statement on behalf of Oracle.
Members of the subcommittee, thank you for the opportunity to speak with you today. The VA's EHR modernization program is at a turning point as we begin work to restart deployments in Michigan. The preparation will take place this year, with the deployments occurring in early 2026. I say turning point because we have several factors that have come into alignment. First, a new administration that is committed to accelerating. Second, we have completed countless optimizations and improvements, including with pharmacy just this weekend, that have improved productivity and are trending user satisfaction in the right direction. Third, Oracle is making a number of investments to make implementations go faster and smoother, improving training and support, while also investing in modernization of the EHR to provide a state-of-the-art experience for providers. And fourth, Oracle is migrating VA to our cloud to unlock a slew of new technologies that VA can take advantage of while enhancing cybersecurity. We believe the program is ready to accelerate deployments in 2026. We are working closely with Secretary Collins, Dr. Evans, and the VA team to figure out the right pace of deployments, timing, and schedule, even meeting at the VA just a few hours ago. As the committee considers the path forward, I think the most important thing to recognize is that the program and the EHR deployed at the first 5 sites is in a vastly different state than it was nearly 3 years ago before Oracle acquired Cerner. There have been many changes to address the challenges of the past. My written testimony details, perhaps painfully for those of you that read it all the way through, the amount of change that Oracle has brought to the program. It performs reliably without severe outages or frustrating crashes for users. It has had more than 3,000 functional changes made during the reset to make the EHR easier to use, simplify workflows, and enhance functions like pharmacy. Training has been overhauled. The new training program worked very well and received high marks from the employees at Level Federal Health Care Center in Chicago when it successfully went live last year. Revenue collections and productivity are returning, and in some cases, even exceeding baselines from pre-deployment averages. Patient safety continues to be a top focus, and we have instituted several new procedures with VA to make sure safety is always at the forefront. User filing tickets with potential patient safety concerns have dropped 80% since our acquisition of Cerner. The EHR has new opioid tools, registries, and clinical decision support tools that enable greater patient safety, close care gaps, and help improve outcomes. Finally, when veterans receive care in the community, their health records can be accessed by community care providers and updated to ensure VA providers have a complete view of the care received outside the VA system. Now, there are still challenges and work that we will continue to do to improve the system to address the VA's unique needs. We expect the same of VA in terms of focusing on standardization, quick decision-making, and displaying a strong commitment to adopting the new EHR. All of this work will continue in parallel while we prepare for the next round of deployments, and none of the optimization work should slow us down. Looking into the future, as we move this system to the Oracle Cloud, we will have the ability to bring even more modern features to the EHR and eventually upgrade it to our new cloud-based EHR infused with AI. The narrative about this program is largely negative. We understand that first impressions last, and the first impression in Spokane and the other initial sites was not good. But we are not Cerner that deployed at those sites. The totality of updates, enhancements, investments, and innovations to the EHR show that this is a dramatically improved system from what was originally deployed in Spokane in 2020. We are encouraged that everyone involved wants to see this program on a path to success or get it back on course, as Chairman Boss and others have said. Because I know we all agree that those who have made sacrifices for all of us deserve modern technology to help make their experiences at the VA more efficient, safe, smooth, and ultimately aid the providers that serve them in delivering high-quality care that improves the health of veterans. Oracle stands ready and committed to getting this done on behalf of our nation's veterans. Thank you.
Thank you, Ms. Verma. The written statement of Ms. Verma will be entered into the hearing record. Mr. Case, you are now recognized for 5 minutes to deliver your opening statement on behalf of OIG.
Chairman Barrett, Ranking Member Budzinski, and subcommittee members, thank you for the opportunity to discuss the OIG's oversight of EHRM. Since April 2020, we have published 22 reports on VA's modernization program. More than half uncovered significant patient safety concerns, such as problem with medication management, pharmacy operations, and patient care coordination. The others identified deficiencies in program and contract management, including poor cost estimating and reporting. We have remained focused on EHRM during VA's reset because an updated EHR has a central role in providing high-quality health care to veterans. I want to discuss 4 main unresolved issues previously identified by OIG teams that VA should address as it emerges from reset to the next wave of EHR deployments. First, While VA has addressed many OIG-identified patient safety issues, more work is needed to ensure that the veteran's experience with the new EHR fulfills its promise of timely access to seamless, high-quality care. For example, the new EHR has had serious issues with handling scheduling changes and missed appointments. This includes VHA allowing mental health staff at new EHR sites to make fewer attempts to contact no-show patients compared to legacy sites, creating a different standard of care between sites. VHA should address barriers created by software deficiencies without compromising patient care and engagement standards. Second, in February 2024, I testified to this subcommittee about pharmacy-related patient safety issues facing every VHA provider. While VA has made progress on some aspects of the pharmacy program, critical issues remain unresolved. For the foreseeable future, legacy EHR site leaders must have providers perform manual medication safety checks for patients who have received care at a new EHR site due to concerns with the automated process. These manual safety checks are time-consuming and rely on the vigilance of pharmacists and frontline staff. Facilities using the new EHR require greater numbers of staff and supplemental resources to manage this significant drop in productivity. Third, it is essential that the new EHR system be consistently accessible. In September 2024, the OIG found that VA procedures lack sufficient controls to prevent, respond to, and mitigate major performance incidents. While we recognize VA has improved system reliability, there are still incidents occurring every month. Given the stresses the system will likely experience during the next deployments in larger facilities, VA must be ready to handle any future instability and equip providers with the tools to continue working when the system is degraded or inoperative. Finally, VA must develop and maintain an integrated master schedule to clearly track and project the program's cost to completion. The 2026 deployments are on a much larger scale with a greater number of variables and tasks to plan and execute. Also, VA's ability to train staff and resolve requests for help may be challenged. Additionally, there may be many developments over the next year that could affect the schedule, costs, or the veteran and provider experience. A reliable master schedule will enable VA to be fully transparent with Congress and their stakeholders about what needs to happen for the successful rollout of the new EHR in Michigan and other sites nationwide. Our recommendations on the integrated master schedule and project costs have been open for several years, paused essentially because of VA's reset. Given the restart, VA should get them done. Without them, costs will be uncertain, risks may not be mitigated, and efficiencies could be lost as tasks dependent on other actions are not fully considered. In conclusion, EHRM's success is dependent on VA's transparency, careful planning, and the recognition and remediation of patient safety issues. Updating the EHR is critical for VHA's ability to deliver health care in the future, and the OIG will continue to focus our resources to provide VA with timely recommendations that can help them and Congress ensure this transition succeeds. Chairman Barrett, this concludes my statement. I would be happy to answer any questions you or other members may have.
Thank you, Mr. Case. And the written statement for Mr. Case will be entered into the hearing record. And now we will go to Ms. Harris, and you are now recognized for 5 minutes for your statement. Thank you.
Chairman Barrett, Ranking Member Budzinski, and members of the subcommittee, thank you for inviting us to testify today on the EHRM program. This is VA's 4th attempt at replacing its legacy electronic health record system. As requested, I'll briefly summarize our recent work on VA's progress to implement the system and the challenges it faces moving forward. As you know, VA provides healthcare services to roughly 9 million veterans and their families, and relies on the legacy system called VISTA to do so. In June 2017, the department initiated the EHRM program to replace VISTA and deployed the new system to 6 of its medical centers at a cost of about $12.7 billion. The rollout of the system has been met with poor user satisfaction, change management issues, and slow resolution of trouble tickets, among other things. Given the magnitude of user concerns, VA paused deployments in April 2023 to improve the system and address those concerns. And on December 20th, 2024, VA announced it would resume deployments to 4 Michigan sites in mid-2026. And this afternoon, I'll highlight 4 key points from our work. First, VA lacks a strategic roadmap to get EHRM where it needs to go. During the 20-month deployment pause, a significant part of VA's improvement efforts focused on the more than 1,500 system configuration changes needed to support user needs and standardized workflows. VA also closed many of its highest priority patient safety enhancement requests. These are all important accomplishments, but there are still about 1,800 complex configuration changes and a number of user-driven projects that need to be completed. For example, referral management lacks functionality and intuitiveness for users, and VA will be working to simplify the existing process and standardize referrals across the enterprise. And all this is to say that VA has been in reactive mode during this reset period, putting out fires with no real plan for how to move forward strategically. Two pieces of information needed to inform such a plan are the cost and schedule estimates. And this leads to my second point, that unfortunately, Congress and VA senior leaders are relying on estimates that are severely outdated and incomplete. Existing cost estimates range from VA's $16.1 billion to an independent one of almost $50 billion. And while the latter is more realistic, neither reflects the many changes and delays to the program. Also, planned system deployment at 4 additional sites results in about 94% of VA's total medical centers without the new system as of mid-2026, with 2 years left on the Oracle Cerner contract. It is vitally important that VA update these estimates to inform decision-making. Another key piece of information needed to inform a strategic roadmap is the results of an independent operational assessment, or an IV&V test, which we recommended VA conduct in 2023. An IV&V is an evaluation of the system end-to-end to determine whether the system is operationally suitable. So in other words, it systematically catalogs these deficiencies of the system and answers the question of whether or not the system will realistically meet mission need. This test is considered an IT best practice and one of the reasons why DoD was able to successfully deploy the Oracle Cerner system. And now to my final point, VA's user surveys continue to reflect general dissatisfaction with the new system. As of September 2024, about 70% of respondents were not satisfied with the system. About half continued to disagree or strongly disagree that the system enabled them to deliver high-quality care. 75% disagreed or strongly disagreed that the system made them as efficient as possible. And while there was a slight uptick in satisfaction compared to 2022, these numbers are still just too low. Moving forward, it will be critical for VA to address these issues along with our other open 8 recommendations as soon as possible. Doing so will position VA to more effectively deliver a modern health record system our veterans deserve. And that concludes my statement. I look forward to addressing your questions.
Thank you, Ms. Harris. The written statement of Ms. Harris will be entered into the hearing record. We will now proceed to questioning, and I recognize myself for 5 minutes. Ms. Harris, thank you again for your testimony. And given all that's happened with this program since its last cost estimate in 2022, I know you mentioned this in your opening remarks, but can Congress rely on the estimate of $32.7 billion over 13 years to fully implement the Oracle EHR at VA? And if not, why not?
No, Congress cannot reliably rely on this estimate. There have been too many changes to the program. There obviously was this program reset over a 2-year period with additional work being done, and none of that has been accounted for within the cost estimate. So that estimate needs to be updated before we proceed, because again, when you take a look at how much has been sunk, $12.7 billion already, and we've only deployed to 6 sites, you know, if you were to just multiply that across the 94% of medical centers that have not had the SIM system, I mean, that could be in the hundreds of billions of dollars potentially.
Thank you. Second question for you. GAO has been publishing reports about the EHRM program and making recommendations to VA on how to improve it since 2020. You've been involved in each of those. How many recommendations have you made? How many have been resolved? I know you said there's a number that are outstanding, but can you give us an update on the number of recommendations versus those that have been resolved so far?
So we've made a total of 15 recommendations in our previous work. We have an additional 3 that we have with a draft report that's out for comment at VA at this time. So that would be a total of 18 recommendations. Of those 18, 1 has been implemented.
Which one was that?
and that one was related to, I believe, data migration.
Okay, thank you. Your most recent report said that the program has made incremental improvements, but there's much more work to be done. Is that related to those recommendations, or do you have other thoughts on the incremental improvements that have been made?
I mean, the incremental improvements have been related to those system configurations that VA has completed, so roughly 1,500 complex configuration changes. And I know that there have been more that are not complex, but that have been made during this reset period. But there's still a significant number of configuration changes that need to be made in addition to these user-driven projects. Those are still outstanding that need to be completed before the deployment at Michigan in mid-2026.
I know you mentioned the, what I would consider lack of satisfaction, or the reports as they survey those that are interfacing with the system, anywhere from low 70s to low 80s are seemingly frustrated or feel like the system isn't meeting their needs or obligations or desires. Do you have any information as far as like an industry standard outside of government or in other health systems as far as the satisfaction among folks with electronic health record systems?
We do have that information. I don't have that with me at this time, but I'm happy to work with your staff in providing that. But I do believe that the industry numbers for the Oracle Cerner system, it's higher than what we're seeing at VA. And at DoD, the numbers are a little bit higher than VA, but overall, that they're not super high compared to others, is my understanding.
Okay, thank you. In your opinion, does VA have a complete understanding of all the problems with the system, and do they have a plan to resolve them?
I don't believe they have a complete understanding of all the issues, and that's why this IV&V test is so critical, because it's a systematic look at the system once it's in the live environment. And so when it's deployed, then the testers go in and they observe the users actually use the system from an end-to-end perspective. They catalog all of those issues, and that would be a way for VA to identify the comprehensive list of issues and then to prioritize from there. So they have not done that. They've done pieces of those types of tests, but not from an end-to-end perspective.
And quickly, I only have about 30 seconds left. How, I know it's the position of VA and Oracle that, well, we've got this in a live environment, so we don't need that end-to-end review. What would you say to that position that they seem to feel is testing it in a live environment?
I mean, I would disagree with that. It's an IT best practice. It's also something that DoD did when they deployed their Oracle Cerner system, and it was one of the reasons why they were able to successfully deploy.
Okay, thank you. I'd now like to recognize Ranking Member Budzinski for your questions.
Thank you, Mr. Chairman. I had mentioned this in my opening. I am concerned about any potential impacts with the recent announcements of some of the workforce cuts to the VA. Is that going to then affect the implementation or the go-lives that we have coming up with the EHRM system? So I think my questions are really for Dr. Evans in this first round. Did you lose anyone in the probationary employee purge, and if so, how many?
Yes, we did lose several employees with regard to folks who were let go who were in their probationary period. I believe the number currently is 8.
8, okay.
Staff.
And then how many people in the EHRM integration office took advantage of the fork in the road email that was sent?
So 16 staff members signed up for the deferred resignation program.
Okay. And then how many vacancies did you have before these cuts started?
Our organizational chart is approved for approximately 330 staff, and we're at approximately 250.
Okay, and so based on that, can you kind of speak to how confident you are that you can move forward successfully with these staffing changes, or how does that impact how you're looking at the potential for success for our next round of go-lives?
Yeah. So I think I'd start by saying, first of all, this is a priority. This, as we've heard here in the room today, our successful implementation of the federal EHR across VA is a priority of the VA and is certainly a priority of current VA leadership. It is important to recognize that it is not just the government staff of the Electronic Health Record Modernization Integration Office who are going to be the folks who actually make this happen. I am super proud of every one of them and the work that they are doing to move this program forward. They have been putting in a tremendous amount of effort over the reset, and now as we are getting restarted in Michigan and beyond, they're doing a tremendous amount of work. We also rely on staff from the Veterans Health Administration, from the Office of Information Technology, from several of our vendor partners who work alongside of us, and really across in the field at the VISNs, right? It takes many, many more than the folks in the program office to successfully implement the EHR.
Okay, thank you. My next set of questions is really focused around the restart that was put into place, and then obviously this recent news about going live with some sites in Michigan in mid-2026. My question, just to start again with Dr. Evans, is just can you talk a little bit about how confident you are, given what you've shared and what has already really been shared with the panel, that the VA and Oracle are ready to deploy this system, and that we will not hear the same concerns that the first 6 sites raised?
Yeah, I think good program management and sort of a realistic approach to implementing. I think we should step back and recognize that this is a really complex, transformative change. We are changing effectively all of the information technologies that support healthcare delivery at our sites. I feel confident that we are in a much better place and completely agree with the fact that what we are deploying, the product we are going to be deploying in Michigan, the set of technologies and how they are configured to meet VA's needs, it is an entirely different set. It's very different than it was with the initial sites. And so I do feel confident that we are entering Michigan having learned a lot, having listened to our end users, but that doesn't mean that we can let up one bit with regard to our vigilance of how do we deliver with excellence in Michigan.
So I think maybe drilling down a little bit more, like, are there metrics that you're using that give you the confidence to say that?
Yes, we established a set of metrics that we used to demonstrate our progress during the reset. They were looking in 4 categories. One was essentially how stable the system was, the technical stability of the system. The second category was looking at metrics around the program processes that we use to support end users. How well are we supporting the need for change and for adjustment to the system and support for our end users? The third was around the veteran and VA staff experience around a host of pieces of the application. And the fourth was around the actual impact of the system on health system operations, our revenue collections, healthcare quality, et cetera. We've been tracking those metrics through the reset, and we will continue to track them as we move forward.
I'm run out of time, so I yield back. I have other questions.
Sure, thank you, and we'll do another round after this. Mr. Luttrell.
Thank you, Mr. Chairman. Ms. Harris, you look like you want to respond to that, what Dr. Evans just laid out for us.
Sure. I mean, there's been a tremendous amount of work that was done during the program reset period. There's no doubt about that. There are a lot of very important accomplishments, but at the same time, there's still a very large amount of work that needs to be completed with regard to the continued changes to the system, the configuration changes, as well as these user-driven projects. That in combination with what they are doing in parallel, which is getting these 4 sites ready to go live. I mean, that's going to take a tremendous amount of resources. We know within, like, the FHCC, for example, in Chicago, that there were some resources that were redirected from that system work to get the sites ready. So our concern is, in the absence of an integrated schedule, as Mr. Case has been talking about, as well as a cost estimate to really know what it's going to take to get to that go live. It's just a big unknown.
Thank you, Ms. Harris. Dr. Evans, why didn't the VA conduct an IDV test or assessment? IDV?
Yes, an IVNV.
Thank you.
I think,
Considering it worked for the DOD, I'm curious why.
yeah, it's a good question. First of all, I think we've had a lot of attention in a very similar fashion to what an IVNV test would do with our staff and frankly staff from Oracle Health spending a considerable amount of time on the ground at our live sites, observing workflows from end to end and categorizing where the issues are. And those issues are the change requests that we have been working through during the reset. And you heard of the fact that there are 1,800 still that we are working through at the moment. Those are the change requests that have...
Would that assessment have problem solved instead of doing it the way that we did conduct it? I only ask that because we failed miserably. Would that assessment have solved that problem?
I mean, I don't think that it would
Because
have...
help me out with the numbers here, on a $10 billion project, we're 12 and a half into it, projected to go to $50 billion.
So here's what I would say is I think that with regard to identifying the issues that we need to fix, I think we have had an awful lot of help from our end users and frankly from our staff in identifying what those issues are that we need to fix. I would welcome a third-party assessment of what additional issues might be discovered, but I don't think we're going to find a significant set of surprise issues that we're not yet aware of.
I would imagine there's a whole laundry list of them, considering what the OIG just said. Ms. Verma, how long have you been in your position?
I've been in my position for about a year.
Of course. So Cerna, Oracle bought this project from Cerna, or I think it's the best way to say that, correct?
Oracle acquired
Acquired it?
Yeah.
And then I'm sure they were very well aware of the problematic issues that existed inside the EHR.
We've gotten more fully acquainted with those, yes.
I'm sure you are, considering where we stand today. What is your, give me, because you said update costs. I'm curious, what is Oracle projecting the cost of activating the EHR? Not in 2026, but downstream in all 172 facilities, plus the satellite campuses that you and I spoke about, Dr. Ev, when everything's up and running, what are we going with, considering we're well over our original budget?
So agree, just from a taxpayer perspective and former government official, I sort of understand the need to really be very careful with how we're using resources. And so just a couple of numbers. I heard the $50 billion estimate. I think that's an outside group that we haven't validated, so we don't agree with that estimate.
And you can't say you disagree with $50 billion and it costs 49.
Agree, but I don't think it needs to go to that level. I think there's a lot of opportunities for us to figure out how to run this program more efficiently. The other thing I would say is that out of the $10 billion, Oracle's received $5 billion. So there's some of the other estimates. Not all of that has gone to Oracle. I do think that the way to make sure that we're using taxpayer dollars efficiently, there's a couple of different things that we can do. Accelerating is really important. The longer the program goes on, the more that it's going to cost. There's also opportunities, even things around standardization. Like we've heard a lot of discussion about that, but when we standardize, we also reduce the number of additional configurations. Even if we can get done some of the work around optimization, that also will decrease some of the, later on, some of the additional work that happens. Integrations.
Sorry, Ms. Verma, I apologize, Mr. Chairman. Are we doing? Okay, forgive me, I'll circle back with you. Thank you, Mr. Chairman.
Thank you. I recognize myself again. Dr. Evans, the IV&V, you said essentially, not to paraphrase what you said, but more or less that your users have accounted for what that would do by utilizing the system and providing change requests to that. To me, not being an IT professional, that sounds a lot like we're going to put it out there, and even though we know it's not fully operating properly, we're just going to wait for people to tell us where it's broken and wait for it to then roll in for the fixes that do that. If we had planned this from the beginning and done that thorough analysis that Ms. Harris had described, would it have prevented that need for so many changes that are now backlogging the system that are putting us in the position of delay that we're in currently?
I think, so a couple things, right? When we look at the DoD's experience deploying the EHR, they had a very similar experience. So though they did complete an operational test, an OTE exercise to determine the suitability of the system, they did not do that until after it was already in production and was being used at several sites, when they were having very, very similar problems to VA's initial problems. I think so that's point number one. Point number two, I completely agree with you, right? End users are one piece of the puzzle, but bringing experts in who can watch and observe and provide insights that an end user themselves might not be able to sort of provide from the foxhole in which they are is valuable. But we've been able to do that with experts from the program office, from our council, experts at the national level in VA, from Oracle Health, from our research community who has very carefully studied different parts of our implementation. So again, I think we have learned quite a lot, not just from end user reports, but also from external bodies who have looked at our implementation.
Okay, Ms. Verma, you said that, a big portion of reducing costs is accelerating the implementation of this program. And while I suppose I agree with you that from a strictly cost standpoint, if we were to just implement this everywhere, maybe we could save some money, but I don't think that you would have the confidence of this committee. I'm not going to speak for the other members, but certainly from my own perspective, given the track record that's been out there so far, asking us to endorse the idea of accelerating this when it has not proven to be adequate, and that's putting it in the most diplomatic way I can. What can you give us to reassure this committee that, in fact, accelerating is the appropriate thing to do when we are, the last time we implemented this, we had to go into an immediate freeze because it was so poorly implemented?
Yeah. So I think we're in a different place than where we were 5 years ago and even just the last 18 months. If we look at the track record, even in respects to testing and independent evaluation, right? If we look at the go live in Chicago, that has gone well. If we look at even this weekend, I know time will tell, we'll get a better sense of the impact on our providers. But I think if we just look at sort of in the recent history that we've actually seen some good, successful deployment.
But wouldn't you agree that the go live in Chicago was done with a significant assist from the Department of Defense working in that regard as a spotter on the weight bench, if you will?
I think that the DoD certainly helped, but the VA was there. The VA led that, and I think there were a lot of lessons learned that will help them also take some of those lessons in going forward. There's still a lot of, if we look at the history in terms of the impact that it's had, I mean, even on productivity, there's some places where we've actually increased productivity in some places. We've also seen some of the work that we're getting in terms of closing care gaps. Some of the new tools that we've been able to provide for providers on the front lines that have actually helped them deliver more safe care in terms of opioids, for example, the clinical decision support. So those are things that I think are definitely helping.
And I heard that in your opening remarks, and I appreciate the focus on that, but I'm curious why, we don't have, to Mr. Case's point, we don't have a standardized schedule as to when this is going to be implemented. To Ms. Harris's point, we don't have that end-to-end review and analysis of where the pitfalls and gaps are. And if the answer is to go faster, I don't think that a reasonable person would view that that is the most appropriate thing. And I guess with 15 seconds left, how can you reassure us that that would be the case?
Look, we're committed to making sure that this works. I think the history shows, the recent history, that things have improved. The VA is paying for hosting. They're paying for a lot of things that they're not using. And so if we look at where we've been just over the last 12 months, I think things have started to turn around. They have started to go well. And so, we're committed to getting the optimization work done, as well as in parallel, trying to advance some of the work in terms of going forward at these other sites.
Our version of what good looks like might be out of sync with one another, but I'll be curious to ask more. But I want to recognize Ranking Member Budzinski again for 5 minutes.
Yeah, thank you very much. And I actually want to just kind of build on what you were talking about accelerated deployment. What would it take for Oracle and the VA to be able to accomplish that? If you could kind of further, both Dr. Evans and Ms. Verma, if you could elaborate on that.
I think from my perspective, one of the biggest things that we need to do is standardize, right? If we get to a sort of a standard set of configurations, that's going to really help a lot.
I know you've said that a lot, not to interrupt you, but I think one of the things that I've come to understand and appreciate in some ways about the VA is every clinic is different, every C-box different, and the uniqueness of it, is that a bigger challenge within the VA than it is perhaps with the DoD when you say standardization?
But if we think about the original goals of the program, right, was to create a standard, some standardization so that when veterans go into one site, they're getting a similar level of care, a similar quality, a similar standard of care. And in order to do that, we need to make sure we're all operating in the same way, and that starts with having the IT configured in a way that is standard. So that, I think, that in and of itself will create a lot of optimization, even if we think about a lot of the configurations and a lot of the different requests, because I think there is the expectation that we're going to do this in a bespoke way, and that's actually contributing to more complexity and increased costs and increased difficulties with training and support if you're doing something different at every site. And so, when I say that I think we can go faster, that is predicated on having standardization. That is key to be able to go forward and to accelerate.
And it's not, and I believe in this program, so I think that I believe in the standardization concept. That's what we're moving toward, but I'm more asking you the unique challenges within the VA to moving to something that's standardized, that is something a little different than the DoD.
Yeah. I think one of the things that and we've talked about this and been working on that is how can we, give more support to the providers on the front lines, making sure that they have adequate training. I think that the work that we did in Chicago was a good example of that. Not only did they have a lot of training in advance, they also did elbow-to-elbow training so that when it went live, there were people circulating there that could give them support. And that's not something that should just happen on the first day or the first 3 days, right? It still may take about, even a month later. We find that a lot of the requests and a lot of the changes that people are requesting, sometimes those are rooted in, they may not understand how to use the system, and if we actually give them more support and more training, that they actually aren't going to request a change in the actual system. So I think that's also a piece of it, the standardization and more support, more training.
Okay, Dr. Evans?
Yeah, I think, and I think the original question that you asked was, how do we feel confident about the ability to accelerate, and what does that look like? I think I'd start my remarks by saying that I mentioned it in my opening statement, but I'd like to underline it. VA is and agrees with the recommendation that we do need a revised integrated master schedule and a life cycle cost estimate regarding this program. 100% agree. And when we made the decision to start our work in Michigan, we made that decision very explicitly. We spoke to this committee about that decision to say, we are making a decision to start moving towards Michigan with the understanding that we need to, in parallel, be working on the schedule, the integrated master schedule, for what things look like to get to Michigan, what things look like to get to the sites thereafter, to the end of this current contract, and to the end of our delivery. So we agree and are working on the schedule. And I think, one of the things that I sense that you're trying to get at, which I would very strongly agree, is that the details matter when it comes to executing a complex project like this. The details matter, and that's what we capture in an integrated master schedule. We are at a very different spot in the program than when this program began many years ago. And so sort of snapping the chalk line and starting to build that schedule iteratively, we have heard that recommendation from both GAO and OIG, and we will do it.
That's great. That was going to be my next question, is getting that schedule. It's great to hear that that's something you'd be open to. Just because I have only just a few seconds left, can I ask you really quickly,
Yes.
Dr. Evans, about the 3B pharmacy solution and that was rolled out? I know we've talked very briefly about it, but can you generally just say, how did it go this weekend?
It was rolled out this weekend. The block upgrade, which is twice a year, we introduced significant software upgrades to the federal EHR that occurs in February and August every year. This block upgrade runs from the 21st to the 28th. Much of it was implemented over the weekend. There were a few small issues addressed this morning, but overall, it's a little too early to tell, but it seems like things are going well with regard to 3B.
Thank you. Mr. Luttrell.
That's curious to hear what you just said about the pharmacy, because Ms. Verma said it was going great, which it kind of works in conflict here. Can you elaborate a little bit more, Mr. Evans, on how that pharmacy, when it was activated this weekend? Because I'm going to go back to Ms. Verma, because, again, I want to kind of unpack the suitcase on this.
Sure. I think probably, as you and the committee are aware, it's been a long journey to deliver this particular improvement. When we first went live with the pharmacy capabilities to support VA, and again, remember, pharmacy operations in VA are a little bit different than in a typical commercial healthcare environment. VA runs both the healthcare delivery organization as well as the pharmacy fulfillment organization, both the pharmacy that's dispensing the medication and the providers and staff who are ordering those medications. As we deployed pharmacy at the original sites, the pharmacy community came and identified initially a set of 7 issues that they said were absolutely critical for us to deliver before we went live at a level 1 high complexity site. Of those 7 capabilities, one of them happened to be numbered 3 and proved the most challenging. We had hoped to have that delivered last February. There were some issues with it, and there's been a lot of work, including a very different approach to how we did development and testing and evaluation of 3B to get it delivered this week. I just, in the interest of full transparency, as with any
We
IT
appreciate transparency.
Yeah, with any IT go live, when something hits the light of day, you might find something that you may have done absolutely extensive testing, and there may be some small issue that you identify, which has been quickly fixed this morning. And so that's what I'm talking about. I would say overall, it is great. I would agree that it is great that we are live with 3B now, and that we are going to be able to see how that works in the real world over the next week and the following weeks. And that is good news.
Ms. Verma, I know you're representing your company, and you're giving us a kind of a grandiose expectations of the success that is currently happening. But we're in the basement. We're in the basement. We're at bottom. We're rock bottom. We actually have failed totally because we're in the pause. Can you give me a statistical probability of success in the next 2 years from Oracle? Because if it's not successful, the only person that's going to be sitting here taking the punches is him. But I want to hear from you and Oracle, if you think I need to hear this out loud, where we are currently when we go live in 26 and then running in parallel with other facilities, correct, Mr. Evans? Is that how you explain that to me in my office? Is that going to work?
Listen, we're committed to doing everything that we can. Right?
No.
I can't.
Everybody says that doesn't have a plan.
Right. Well, I think we do have a plan. We've talked about a number of optimization projects that need to get done. We're talking about how we implement in Michigan. We're going back and looking at lessons learned and how we can implement it in a way that supports end users with better training, with better support.
So you're highly confident Michigan's going to fire up successfully?
I'm confident, yes.
Give me a statistic.
I'm not going to give you a specific number, but I feel pretty confident about
Better
it.
than 50?
I think it's going to be better than I think we're going to be building on all the improvements that we have had over with the optimization work and some of the lessons learned in terms of training. We're also putting in a lot of time and effort to figure out how can we figure out how to optimize and how to make these go in a more smooth way. So we're also building on a lot of the experience that we've had, a lot of the challenges that we face. We've actually learned from those, and so we feel comfortable going forward and that this is going to be better. And I will say this, if we just look back, right, if we just look at Chicago, that has gone well, right? And that's the only implementation that was done by Oracle. That has gone well. And if we look at these recent code block releases, this isn't the only one that we've done. We've actually done several, right? We did one in August, we did one last year, and we've seen that those have gone smoothly. And so if those hadn't gone smoothly, I could understand that there would be some concern. But if we look at in the last year, right, Chicago has gone well. All of the last 2 to 3 code block releases that we've gone have gone fairly seamlessly. Yes, there's little bumps and things like that we've been able to get through, and they've gone largely successfully. So if we look at the recent past and the turnaround in terms of Oracle coming in, stabilizing the system, a lot of the problems that we've had have been addressed. The stability has been addressed. We've been able to do a good go live, and we've also been able to upgrade the system in several different areas successfully. So those areas, that's why I feel confident that our next go lives will go well and that we are capable of accelerating.
Thank you. Mr. Chairman, I yield back.
Thank you, sir. I will recognize myself again. So coming to Michigan, 2026, we have level 1A complex facilities, right? Ann Arbor and Detroit, correct? Have any of these been rolled out in complex facilities up till now?
I can start with that. So the James A. Lovell Federal Healthcare Center in North Chicago is a level 1 facility.
Okay.
So the short answer to that question is yes. I think I'll further answer your question that I'm very, very impressed with the leadership teams at all 4 sites in Michigan. I've met personally with each of them as we're getting things kicked off. And in part, in answer to Mr. Luttrell's question as well, one of the levels of confidence that I feel in Michigan is this is as much about IT implementation, whether the software works, as it is the sort of personal and human, sort of all of the staff at Michigan adopting, getting used to, working through the change of adopting this new system. And I'm very proud of the work that the teams in Michigan are doing to prepare. I think that should also sort of raise our level of confidence of success there.
Okay, Dr. Evans, what are some of the incomplete Big Rock projects that you described in your remarks earlier?
Right. One of those is an example of one of those is what we call position standardization. The way the Oracle Health Record, or what we call the federal EHR, works is a user, depending on what type of user they are, has a different experience in the software. So whether they're a social worker, primary care provider, a rheumatologist, an endocrinologist, which type of physician, nurse, et cetera. And there are more than 300 different roles configured into the system. We've learned at our sites that there were probably too many roles that were chosen by VA when we started down this path, and have been consolidating and standardizing what can be done in those roles. So we just completed standardizing the roles for advanced practice registered nurses, geriatric and extended care providers, and social workers, and took what had been 28 roles, that's 28 different training programs, 28 different sets of software capabilities to maintain, and compressed them down to 6. And we're now starting with the nursing roles, RNs and LPNs. There are more than 50 nursing roles, and we anticipate compressing them down quite a bit. Again, as we reduce complexity, it will improve the sort of the efficiency of training and the user experience as well. That's an example of one that's very, very important that we are tracking towards making very significant progress towards prior to the Michigan go live.
Okay, are there any remaining Big Rocks that are showstoppers that if they're not done, it will inhibit the ability to roll this out at the next phase in Michigan?
No, I wouldn't say that they are showstoppers.
Okay. Do you feel right now, I guess I can ask Ms. Verma this, is the system ready to go live today in Michigan if we wanted to? Like, do you have confidence that we could do this right now if we chose to? That's for you, Ms. Verma.
Oh, I'm sorry, that's Dr. Evans. I'd say a couple of things, right? So if we look at the system that we have today, we're making changes, we're doing optimizations. I think that this year we should continue to do that work around optimizations, and so that when we do implement with Michigan next year, which is what we're slated to do, that will go well. So, and it should go better than the initial 5 because we will have identified what those optimizations are and what those need to be. And so if we implement those now, that will make Michigan go better next year.
So going back to when the initial rollout happened, the number of facilities we've rolled out, North Chicago, the whole thing, and the pause, all of that, today you don't have confidence that the system would be ready to go in its current state?
I think that we can implement a system today anywhere. However, there are some opportunities to improve the experience, and I think we've agreed with the VA to do that work and do the optimizations, do that before we go to another deployment. But the system in and of itself, yes, that can be deployed anywhere. I mean, the reality is our EHR is being deployed all over the world. The DoD is using it. And so from a technology standpoint, yes, we can implement it. But I think the VA, and we agree that there is some optimization work that would make that deployment go in a much smoother, better way, and that it's worth making those investments today.
Okay, I'm out of time on my question. Ranking Member, go ahead.
Thank you, Mr. Chairman. I wanted to zoom out again to the accelerated deployment that we had talked about, that plan, and I wanted to specifically get OIG and GAOs, if Mr. Case and Ms. Harris could you also share with us your thought about the accelerated deployment idea by 2028 or 2029?
Yes, to comment on whether it's feasible or will it work, we need to see the schedule. We need to see the master schedule. How do we get from where we are now to where it is that they want to be, whether it's in Michigan or some accelerated schedule? Show us the steps each way. How long is it going to take? What are the risks that it won't work? What's the critical path? How do you modify this if something doesn't work or is not timely, and how much it will cost? So to really assess the viability of any acceleration, show us the schedule, show us the details, and then everyone, Congress, VA itself, OIG, GAO can evaluate it and evaluate the risks. And so I think that's really, from our perspective, one of the issues. And one thing we haven't talked about much here is, so far, is our first recommendation of our first report was for VA to assess what the impact was on productivity at sites and how to address that when it happens. Some loss of productivity is expected, but how much? What's the rigorous analysis of the loss of productivity? Not just what happened at level, but we've got to be honest with ourselves. We're going forward at 4 sites, including 2 complex sites. And how long will that be, and what are the efforts? And we haven't seen that analysis yet, so we could close a recommendation, ma'am.
Could I just, before we go to Ms. Harris, the loss of productivity, could something like improving our training get to addressing some of those concerns?
That should be able to do it, ma'am. I mean, we did a report on the training at the early sites. It was insufficient. And since then, my understanding is it's been improved, but we have a new system. We've heard that again. It's a different system now, and whether the new training that's going to be done will be effective in the new system, that remains to be seen, especially going forward at 4 sites.
And could I just ask you, Dr. Evans, because I know we've talked about the schedule, and obviously Mr. Case just emphasized that as well, but the importance of it, that sounds like something the VA is committed to maybe, not maybe, but to definitely putting together.
Yes,
Did
absolutely.
I hear that right?
Yes.
Okay. That's good. Okay, can I ask you the same question, Ms. Harris?
Absolutely. And before I respond to your initial question, I just wanted to add on with regard to the training. We've heard a lot from Ms. Varma regarding the training, but the training really needs to, the ownership of the training must reside at VA. And many of the pitfalls that they had with the initial 5 sites was they sort of relinquished that control to Cerner to do that training, when VA should be responsible for it, because the VA users are the ones that know the legacy system better than anyone else and what it takes to be able to train up on the new system. And so my understanding, we made a recommendation that VA must improve their change management strategies. No doubt training is a huge component of that. My understanding is that they're still working on that, but that should be finalized and be very detailed before they go forward with a go live. And in addition, just with regard to just are they prepared? I mean, they've got, if they deploy in 2026 to Michigan, I mean, and that's a huge if for all the reasons that Mr. Case has stated, but you still have 2 years remaining on that contract with 160 sites. It's impossible. The answer is no, they're not going to be able to deploy to all of the sites within the remaining time of the contract. But to get to Michigan, at least, as Mr. Case said, we need that integrated schedule. And if they do deploy, Dr. Evans mentioned something very important about DOD, which is, they did the IV&V after that initial wave of, so it was multiple sites that they deployed to before they did the IV&V. It could be a very good test, I think, if they were to deploy to Michigan, to have that IV&V done at those 4 sites. Again, an independent look, not VA, not Oracle Cerner, to do that review so that we can identify in full, end to end what those issues are.
And just to go back to that point, because I know we've talked about it a bit, but to just hear from Oracle and the VA, if the IV&V test, like if there's some added value to a third party helping us take a review, look under the hood, I feel like I've heard there's not necessarily opposition to that. That could be maybe helpful. That's a question, I guess.
So what I would say is there's a cost to that, so that should be part of the calculus here. The second thing I would say is that if we look at the more recent implementations in these code blocks, the testing that we've done has worked well, right? We've actually made changes to the testing program. We've given them different environments to help their internal process of testing, and it's actually gone well. So it could be that an IVV maybe a few years back would have been helpful, but I think we're in a different place now, and the testing program that we have has worked well. If we just look at the recent past with the last 2 or 3 code block releases, I think they've gone better. And I think if you are going to go forward with IV&V, to think about the additional cost of that as well.
Okay, great. I yield back. Thank you.
Thank you. Mr. Luttrell.
Thanks, sir. Mr. Evans, what's the, I don't really know the best way to say this, but like standard of success for Oracle and what that they need to meet in order to say, hey, look, this Michigan's good. We're moving. Which one's the next site? I mean, because we went into the pause because the standards were not met. Are they required to meet the standards that currently exist, or have we increased those standards of success?
I think I mentioned earlier that we've worked on some metrics that we are following, and actually, frankly, with Oracle Health, we follow many more metrics than are actually on our the dashboard of the 9 core metrics that we followed during the reset, and that we will continue to follow as we move forward. So we've defined the thresholds for success for each of those, with the exception of one that we are finalizing now after we did a burn down of trouble tickets. And are resetting what the normal should be. So you may see that in a GAO recommendation that we need to set our targets and thresholds. We've set 8 of the 9. The 9th will be set momentarily. That will be a measure of how we measure success, but there are many others. Really, to me,
So Oracle needs to meet those 9 standards.
Right.
Before we consider Michigan a success, and then we flex to the next facility?
Right, and I think those standards are, these are some of the metrics are operational metrics, right? It is how we measure quality of care at our facilities. It's access to care for veterans. It's wait times.
Let me break this down a little bit further. My question is, at what point in 2026, when Oracle activates Michigan, there's going to be those checks in the box? Now, if they get 3 out of the 9, are they good to go, and that's considered a success, or do they have to have all 9? Which I would say, obviously, you need all 9, but I'm asking you.
My preference is that we're meeting our goals across the board. Now, having said that, I would say we are deploying the federal EHR in Michigan, right? This is a partnership that VA and Oracle Health are going to need to do this together to success, and frankly, with the local leadership in Michigan. And so the success here is a shared project. I would say that is number 1. But number 2, I'd like us to see us meeting our goals across all of the metrics.
So I'm still trying to dig an answer out of you guys. My concern is that we kick the can down the road. We activate in Michigan, and we only have a certain amount of successes out of those 9. Like, hey, look, this is good enough. We're just going to go further, and Michigan fails. And then here we are all over again. We have to go into another pause. We're projections well past $50 billion. Because of where we are currently, there has to be a line-by-line check that says we are absolutely solid, Michigan is good to go, 100%, and now we're moving on. In my opinion, that's exactly where we are, considering how many dollar bills are going to this project. I don't know if you can answer that question or not, Mr. Evans, unless you want to.
So I mean, in short, I could say yes. The system's got to be stable. It's got to work for our end users. It's got to work for the operations of our medical centers, period. And how we measure that is something that I meet with the committee staff on a monthly basis, and we go through those metrics, and we will continue to review those as we lead up to Michigan. And frankly, we're going to use
Will
those.
you move out of Michigan? Is there an end date for Michigan where like we activate here, we got 2 months, and then we're going?
So we go live at Michigan, and then, typically we're looking to see operations restored at the medical center in the 3 to 4 month time frame after a go live.
So 3 to 4 months at Michigan alone.
I think one of the things here, as we talked about earlier, right? If we wait, we have a challenge in front of us, right? The longer VA operates as a healthcare system with 2 different electronic health records, the more risk that we are taking on. And so we have to balance the need to move forward towards a single electronic health record to support an integrated national healthcare system in VA. And if we're going to move forward with the federal EHR, which is our plan, commitment, and desire, then we can't just wait for Michigan to be over and spend another year deciding whether we were successful or not. And so we're going to have to measure together as we move forward our success month to month. It's one of the reasons why I meet with this committee every single month. It is because we need to be assessing our progress at that frequency. And so, because if we don't start to do work at sites beyond Michigan, we'll get to the end of Michigan and we're going to have another 18 months to wait for the next go live.
What if Michigan, sorry, Mr. Chairman, I'm over, but
Sure.
I think you know where I was going with that one. If you want.
Yes.
Thank you.
And I'll come back to you in a moment. Okay, so Ms. Harris, I want to go back to your earlier point. Assuming we roll out in Michigan in 2026, that would give us how many sites have had the new electronic health record implemented at that point?
10 sites,
10 sites. And how many would remain?
160.
160. And it's your opinion in your testimony that it would be impossible to implement the remaining 160 by May of 2028. Is that correct?
That's correct, based on the previous track record and also based on the fact that, all of these sites are very bespoke, they're customized. And so the change management associated with each of these individual sites, I don't think you can standardize that. I think some might take longer than others. And it's just very hard to predict, but collectively, within a 2-year time period, considering it took them, basically, 6 to 7 years to implement at 10, and you're talking 160, when you compare that, to me, there's no way they're gonna get that all done.
Right. Okay. Ms. Verma, obviously the next question for you is, are we going to be through the next 160 sites by May of 2028?
Yeah, I think there's a lot of variables here, right? There's a technology piece, there's a training piece, there's a people piece of this, and so there's also internal processes at the VA. And so, we've been
I think
working.
a simple no would probably be the easiest answer.
We've been working with the VA around acceleration and how to do that. And there's multiple things that need to be addressed in order for us to move faster and to move quicker. And I think we're working towards that, right?
But yes or no, is it your position that this can be implemented by May of 2028 in
From a
all these
technology
facilities?
perspective, yes. But there are other pieces of this that have to come along with the technology.
But we live in the real world that we live in. We don't live in the just hit send on the computer and it
Right.
works.
Right.
Understanding the real world conditions that we're in, understanding we don't have a schedule, to Mr. Case's point. Dr. Evans, do you feel that there's any possibility we can be implemented in the remaining sites by May of 2028?
No.
Okay. Mr. Case, do you?
I don't see how it could happen. I'd like to see what the plan is if they were going to do it.
Okay. Ms. Verma, do you feel that this is even possible? I mean, can we even pretend anymore?
Like I said, we're responsible for the technology standpoint, and we've said to VA, from a technology standpoint, that may be possible, but there's other pieces that go along, and we'll acknowledge, right, that the VA, whether it's standardization, whether it's integrations, there's a lot of things that would need to happen to be able to meet that timeline. We are committed to doing that, however, that there is also other pieces of it, and we would need to work with VA on that, and we're having discussions about that, about what the timeline should be and what the schedule should be. And what are the things that need to happen to be able to accelerate?
Okay. I think even with acceleration, it's impossible to expect that we can be anywhere close to that by May of 2028. Now, Dr. Evans, to follow up on Mr. Luttrell's point, assuming we're in Michigan for several months, I think he was getting to the point of what if it isn't good? What if it isn't working? What if the checklist isn't adequate? What if we're stuck in the position we were in the initial rollout? And what if these aren't going as well as we would like? What happens then? Do we go into another stand down freeze? Do we keep accelerating as Ms. Verma has, suggested? What do we do then?
Yeah. It's an excellent question. I would say this. I think we have to succeed. And I think we should be
Right,
looking.
but I would have said that 7 years ago, too. I mean, we had to succeed then, and we didn't, leading us to where we are now. So I agree with you, we have to, but we have to acknowledge the track record that led us to where we are now for the, reality in which we're facing.
Right, I understand that. And but I still believe that we need to succeed, and we need to be working towards Michigan with the understanding that that is what we must do. Your question is a question of, well, what would we do if we did not succeed? I think we'd be having some very hard discussions right here in this room, most likely. But where I am working with our team, and frankly, where we are working in VA across the agency, is to say this is something we must do. And I'll tell you this, in Michigan, they're enthusiastic. The sites are enthusiastic in Michigan. One of the things that I think you're well aware of in Michigan is that the sites in Michigan work in a very interdependent fashion. Specialty care for veterans who are receiving care in the Battle Creek or Saginaw system often is delivered through Detroit or Ann Arbor. Lab services are shared across the VISN. So the idea of the opportunity to move from 4 separate instances of an electronic health record supporting 4 separate VA medical centers that are trying to operate more and more like one, they look at the opportunity here to have a single electronic health record for all 4 sites to support their sharing and care for veterans in the Michigan market as a huge opportunity. And I think we should feel some level of confidence when the sites are saying this is something we want and that we're ready for.
All right, thank you. Ranking Member Budzinski.
I appreciate that. I wanted to actually shift gears a little bit to AI as something that Oracle had talked a little bit about in the written testimony. Can you explain, Ms. Verma, how AI is being used in this instance?
Yeah. So a lot of the AI that we're going to be deploying will come in sort of the modernization. I will say from the outset, with whatever AI that we do deploy, is that providers and physicians are always in control, right? This is not AI doing things, but giving options and helping and supporting, but decision-making about clinical care and all workflows. There is a human in the loop. So I'd start out by saying that. I think what we've done to improve the EHR sort of outside of VA, but that can be applied and we're willing to provide to the VA. For example, we've brought something called our clinical AI agent, right? Which can, if the patient agrees and the doctor's on board with it, you can have listens to the patient-doctor interaction. It can generate a note. So that's one of the first things that we've brought to the market. The second thing that we're bringing is a brand new EHR to the market, and that has AI infused across all of it. So if you think about a physician coming into seeing a patient, today, in really any EHR, you have to do a lot of searching. Look at their labs, look at all their previous diagnoses, and especially for a veteran where they have complex healthcare conditions and they have multiple comorbidities, that's actually quite complex. What AI can do is give them a summary of the patient. It can detail, here's all the different things. The other piece that AI can do is it can help actually provide guidance to the provider and say, okay, based on this veteran's health condition, here are the care gaps. That is actually, we're actually bringing that in today. But AI can also, if the provider has questions, bring me this, or it has a specific question, it can actually ask the EHR that, and that just, that's actually given. The other thing that we can do with AI is we can identify if there's research going on in the facility, and is this patient a candidate for the research that's going on in that facility as well. I would say that AI is also going to automate a lot of the manual work that we see going on with providers, especially in the area of our reimbursements and collections in that particular area. There's a lot of manual work that goes on with that today. Think about scheduling and administration. And so that's where I think by applying some of this modern technology, there's also some efficiencies to be gained by the VA as well. And it allows the providers to spend time with the patient and not doing a lot of administrative work.
And is this, that type of innovation, is that covered under the current contract, or will there be additional costs associated with that?
So there's some pieces like our clinical AI agent, which are in scope. In terms of the new EHR that we are bringing to the market, we are committed to providing that to the VA at no additional cost. So even though our contract specifies Millennium, our leadership has agreed that we would like to provide that to the veterans because we think that that's going to give the most optimal experience, and it'll improve care and quality for veterans, and that's the most important thing, so we're committed to doing that.
And how does Oracle look at quality and safety as it relates to this issue of AI and veterans and patient care?
Sure. So safety is a high priority. We've got many systems and processes in place to assure that. But I think the most important thing is that when we are deploying AI in anything that we deploy, there's always a human in the loop, right? So this is supposed to be a tool. It's supposed to be an assistant. AI is not a decision maker. So everything that we deploy, and even if we look at things like we're providing, let's say the provider asks a question, we will not only provide an answer to the question, but we'll also identify the source of the data. So let's say we're providing a summary of the patient's history. In the summary that we provide, we'll actually detail exactly where the data came from. So it's not like the provider is getting guidance or getting a recommendation, whatever you want to call it. They know exactly where that came from. So I think the most important thing that we're doing is that the human is always in the loop in these processes. That's how we're applying AI.
And will the system require informed consent from the veteran before AI is used during their appointment?
Yes, and that's completely up to the VA in terms of making sure that those consents and how they want to put those processes in place. I think the most obvious one today that we're already using is around our clinical AI agent that generates the notes. And in those situations, the provider always asks the patient, are they comfortable with that?
Okay. Just going back to something I'd asked about earlier, not on AI, but related, Dr. Evans, when I was asking early on about some of the VA cuts, I'm thinking about cost to staff. Do you expect that the VA might have to take on additional contracts to supplement for where some of the staff might have been cut in order to make sure that we're properly going live in March?
I think it's too early to tell that. We are still looking to make sure that we're optimizing how our current staff is deployed to meet the needs of the program.
Okay. I yield back. Thanks.
Thank you. So Latrell.
Thank you, sir. Dr. Evans, is all of the veterans' healthcare data being moved into the Oracle Cloud?
Yes. We have migrated data from the Vista systems, and actually every day are migrating data from the Vista systems, our electronic health record, into what's called HDI. Health Data Intelligence is an Oracle product that will be hosted in the Oracle Cloud. And that data then is migrated into the Oracle electronic health record to support care delivery. So that when the provider logs in, one of the challenges when you move to a new electronic health record is if you have to start over and find all the information and repopulate the new record with the information, it's a significant burden on providers and staff, nurses and the like to do that population of the electronic health record. So VA made a significant investment in partnership with Oracle Health to migrate a significant amount of data from our existing electronic health record, Vista, into the federal EHR, which should help ease the
Which
transition.
Oracle controls in their cloud?
Well, it's VA's data.
Well, hopefully, God willing, that stays the same. Does anyone, Ms. Verma, is the data that's moved from the VA into the Oracle cloud, is it standalone and no one else can touch it?
Correct. It is a standalone. So all the data rights and everything specify that that's controlled by the VA. It's actually shared between the VA and the DoD.
Okay, but other organizations that work with Oracle and work with Oracle Cloud System, they cannot access that data at all?
Correct. They do not have access to
It's
it.
completely standalone.
Completely standalone.
Okay, thank you. I yield back, sir.
Thank you. Dr. Evans, you said it takes sites on average several months, 3-4 months maybe, to basically fully recover, if you will, and get back to full steam operations after implementing this. Do you feel that the sites that have already implemented this new electronic health record are fully recovered, fully functional, and fully operational right now?
Yeah, I think one thing I would clarify with that is that what we have learned thus far is that the recovery varies based on the specialty, based on where the care is being delivered. So, for example, urgent care and the ER recover their productivity almost near instantaneously, which is important because we can't have volumes decreasing in urgent care and the ER. Whereas in primary care, as an example, in part secondary to perhaps some of the configuration decisions with the electronic health record, in part secondary to the complexity of primary care having to deal with a patient's entire set of health issues, medication management, for example, productivity recovery lags in primary care. And so it's not exactly the same across the entire medical center. Having said that, we are measuring productivity across the entire medical center at each of our facilities. We've seen a positive and appropriate trend at all facilities. And they're, for the most part, at their pre-go-live levels of productivity, actually pre-pandemic, pre-go-live levels of productivity.
So Spokane and the other facilities are nearing pre-go-live productivity marks across the spectrum?
Yeah, I don't have the exact numbers right here. That is on our dashboard. We share that regularly. It's north of 85% across all facilities. Some are above 100%. We can certainly share those numbers.
Okay. And I know you said earlier that we must succeed in this, and I fully agree with you. We have not, though, given, in the more recent discussion just now, given a lot of consideration for the cost. And the cost of this is an unknown at this point. And I think, yes, we have to make this work, but we also have to be mindful and knowledgeable about the costs that that's going to take. And I think to the other, observer's standpoint, that is something that remains an unknown.
Yes.
I don't know if you can
I can agree, and as I mentioned earlier,
expound on that.
we are committed to building out the integrated master schedule. The integrated master schedule is the foundation for building a life cycle cost estimate.
And how long until we can expect to see that?
I think, as I mentioned, our plan is to do that iteratively. So the first phase that you will see is the integrated master schedule for Michigan. What is happening at this very moment in Michigan is what we call the current state reviews that will inform the build of the integrated master schedule by April for the Michigan sites. And then we will begin to plot out the schedule beyond Michigan and build that integrated master schedule. Then to the end of the contract, we are accelerating that effort. I can't give you an exact date right now that will be finished, but we understand how important that is to be able to build the life cycle cost estimate. We are very aware of the importance of getting that information to you and, frankly, others that are at the end of the table here.
But if we're years, plural, into this, and we still don't have the schedule, and we're scheduling the schedule, how can we expect to get that in a reasonable, just to get our arms around it? I mean, our position here as members of this committee is to look at the effectiveness of this, the oversight of it, but also the cost of it. And are we delivering a good value for the people that sent us here to spend their money on their behalf? And we can't even do that without an analysis of what that's going to look like.
Yeah, I mean, and I know this, I don't want to I'm making a promise in the sense that I can promise you that that work is going on right now. I was just in meetings looking at the analysis of cost to date, our projections of what that cost looks like moving forward. We are actively working on the life cycle cost estimate, and I look forward to keeping you up to date. We understand that it is important for you to get that sooner rather than later.
Okay, thank you. I appreciate the everyone here, to our witnesses for appearing today to discuss the future of the electronic health record modernization program. I understand committee members, Ranking Member Budzinski for your closing remarks.
Oh, thank you. Okay. No, thank you very much. I appreciate everyone's time in the panel's discussion and the thoughtful questions from my colleagues. I think one of the things that's very clear is that we all share a lot of really deep concerns about our next go-live date. I'm encouraged to hear Dr. Evans talking about the integrated master schedule and working towards some real metrics that have been recommendations from the GAO and the OIG to address some of these concerns. But that being said, I think it is really important that we're not pressured into this accelerated, the VA, I should say, is not pressured into this accelerated timeline of 2028 by anyone, really just to avoid a potential contract extension, because this really is ultimately about veterans' health care and making sure that they're getting the health care that they deserve and it's being administered to them. So I think we share collectively. I have a lot of concerns. I think we have some steps to address some of those, and I look forward to continuing this conversation. So thank you very much. Thank you, Mr. Chairman.
Thank you. Thank you for keeping me well behaved. And again, I want to thank our witnesses for appearing today. Thank you for the testimony that you provided. I know that many of you spent hours, plural, probably tens of hours, hundreds of hours developing and analyzing this. And as I stated at the beginning, I am new to this committee and new to this Congress and new to this issue, but I am invested in making sure that we deliver the outcome that we all should expect. I know you all understand when I say this is not just an IT system. It has a lot of individuals and their health that depend upon this, the productivity and the morale of the people doing the work, as well as the outcomes for health for our veterans. It directly affects all of them. The veterans that I represent in Michigan's 7th Congressional District are going to be among the first to find out if this system has fundamentally improved since the reset. The facilities in Battle Creek and Ann Arbor specifically are where the majority of veterans in my district go for their health care. So I'm concerned by the talk of speeding up the pace of go-lives, considering the VA has only done one partially successful go-live in the last 3 years with assistance, again, from the Department of Defense. And with the complexity coming with the facilities in Michigan, it gives me a great deal of concern for that. It is far more important that VA does this right instead of fast. The plan is to continue fixing the system's problems while preparing to go live in Michigan, and that is something that we need to be very mindful of. The subcommittee expects VA and Oracle to show that they can get this right before veterans and VA staff in Michigan have to figure it out for themselves. Dr. Evans, I'm encouraged by your remarks that the staff in Michigan are very excited about the opportunity that lies before them to integrate this together in the way that they've been interoperably intending to do in Michigan for some time now. Thank you again for all of you for participating in today's hearing. I want to thank the members of the committee for your questions and remarks as well. I'll ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, so ordered. With that, this hearing is adjourned.